the Chief Information Officer at the HSE, and Fergal will set the scene for us from a corporate perspective. Thanks, Fergal.
Great. I'm very glad Professor Hardick has taken his more time than allotted, so I can take less time than I need to speak. So I'll probably just take 10 minutes. Maybe first thing to say, I confess I'm not a nurse, I'm an engineer by training, but two of my siblings, I'm proud to say, are nurses. So I know quite a lot in terms of growing up with them, in terms of what's involved in your profession. Sometimes when you hear these concepts generally, and we'll talk about electronic healthcare records, you kind of say, gee, that's complicated. And one thing I'd say is I've come from other sectors in Ireland that have done this already. So my first role was with the Irish Postal System, and by 1995 we had touchscreen PCs in every post office in Ireland managing the work of the post office. So it was the first electronic or digital post office anywhere in the world, and the software that was created then is in 80 countries around the world today. We were also similarly one of the first online taxation regimes. Unfortunately, again, as a very heavily taxed taxpayer, as we all are, our revenue authorities are very advanced in terms of their use of technology. So all of these choices are choices these sectors have had to make before, and we've made them in Ireland and other sectors, and I believe we'll be able to make them today and in the future and in the near term in the health sector in Ireland. Again, in terms of confession, I suppose it's only in the last maybe 3 years or so I've been involved in the healthcare sector. Originally working through a relatively small care organisation, you may know it, Our Lady's Hospice in Harold's Cross, which is about 160 beds at the moment. And I've been working directly with the HSE since the start of last year, so just over a year now. So for the HSE, I help. There's a new office, I suppose. It's just over a year old. It's a sexy term for IT. It's called the Office of the CIO. What it does mean is it brings IT up into the senior management level within the HSE. Before that, IT always had to be interpreted or intermediated through another senior manager within the HSE. So it is kind of the first time where people kind of say, health information is strategic, it's important as part of our overall health system. So it does allow quite a number of the programs under that office to kind of get the type of attention that they deserve. Just in terms of kind of the whistle-stop tour, I suppose, let's say, ehealthireland.ie, I'll refer you all to. There's a lot of kind of very regularly updated information on all the range of programs. There are 10 major strategic programs. You'll see them listed there, but just to mention a couple of crucial ones, I suppose, there's an individual health identifier program that will be giving every person in the country a health identifier, and that's being rolled out with 5 consumer systems at the moment. I'm glad to say that just yesterday the last hospital became electronic for e-referrals, so every hospital in the country and every GP in the country can now send and receive electronic referrals. So if any of you go to your GP, I would request that you ask your GP to use the electronic form rather than the traditional paper form. That'll be moving into its next phase, so rather than just sending electronic referrals, it'll be allowing for electronic triage and specialist referrals, etc. as well. And there's a whole range of other programs that I don't have time to kind of cover, but I suppose before I go into EHR, I suppose maybe to me electronic health records give the potential for a longitudinal person's record. To me, nurses are crucial in that nurses spend most time in contact with these persons in terms of their care. So to me, of any of the health professionals that will be dealing with the people who interact with our health service, to me, the nursing profession is probably the most important. So maybe I'll come back to that again towards the end. I'll whistle-stop through this because it's really kind of to give you a flavour for the HR programme. And it's really just an introduction in that it's just kind of underway and starting to be underway. And there'll be plenty, please God, of more opportunities for us to engage on the actual specific programme itself. So really, I want you to have a very high-level understanding of what the programme is, to know what our approach is overall, and to get your feedback, I suppose, on the programme in terms of any input that you believe we should have. And maybe firstly to say where we're at right now is I suppose we've designed the key components of the programme, and we've asked and answered, well, what's the scope of the programme, how much should it invest, and let's say how widespread across the health service should it be. And that's really the level to which we've gotten. Future stages will involve what systems, what terminologies, what functionalities, and all that detail will have to be involved in terms of how we design the actual systems that will be put into place in Irish healthcare. So maybe firstly, I suppose we've done a kind of a design at a very high level and just come across, I suppose, 4 simple components that we see have to be part of the electronic health record system. So while some people say they've got competence in terms of doing single system approaches for entire health systems, we haven't seen the evidence of that. So we've done a lot of consultation with industry and other healthcare systems, and nobody's really been able to display a singular system approach allowing for full integration of all forms of healthcare. So we have defined that, let's say, there would need to be systems in acute and also systems in community healthcare that would then integrate, so they would be able to integrate to allow for one common longitudinal record for each person. And the integration capability would also allow for those parts of our health system that are, let's say, within primary care, so for example GP systems and pharmacy, and in fact I met somebody recently who wanted, let's say, dental healthcare to be part of that integration, as well as private hospitals. So the integration capability as another component allows for all of these systems to interoperate and for the data to form part of a singular record at the end of the day. And then ultimately there's a kind of a national shared record or a summary care record that is kind of the first stop place to go to see all the various episodes and all the various, let's say, data items to do with a particular person. So I suppose that those are the four kind of key components that we've defined that we need to put in place in the Irish health system. So this is kind of just outlining more detail what it does. Then kind of why do we need it? I suppose essentially we're kind of making the argument that it's the fourth utility. You know, healthcare systems can't operate without one in the future, and that's simply what we're saying. As Professor Hardwick mentioned, I suppose people demand an online experience now. You know, we did some focus groups with people, just randomly chosen, and we asked, well, would you like your healthcare record to be electronic in the future, so that, you know, each healthcare organisation could see your information? And the overwhelming response was, what do you mean, it's not electronic already? So that's the ordinary person's expectation. You know, they expect to go online and for all of their information to be available for them and for their carers in a singular profile. We did some direct kind of a user surveying, and overwhelmingly there's a positive expectation as to what EHR will be able to do in our environment. Questions around privacy. Most people would prefer for all of their care professionals to see their information during their care, rather than having to give a specific consent each time that they're going through an episode of care. Benefits, I suppose we've done a kind of sample benefits, and I suppose on a holistic level there are a lot of benefits that we believe will be accrued to the Irish health system. We haven't tried to kind of quantify them. We have given kind of sample benefits, and they're illustrated here now. So in terms of the kind of the journey behind this so far, I suppose there was originally kind of an Ehealth Strategy back in December 2013. There was a kind of a knowledge and information plan, which is essentially the plan of the Office of the CIO for all of its programmes. It was established last summer, and then towards the end of last summer there was a vision for this programme, and now we're literally imminently, I hope, due to publish the actual strategic business case for determining how much we need to invest in this particular programme. So how did we come up with the strategic business case and the approach so far? I suppose we did a number of different kind of workshop sessions that went through, I suppose, the cycle of identifying priorities, identifying then what the solution should be, and then working through the kind of procurement and commercial options that could be used to put the programme in place, and then to work out the plan in terms of what could be done when and what would happen over time. This gives just a little bit more of a kind of an illustration, probably best done on the next slide, in terms of what functionality is where. But ultimately, the shared record gives you summary longitudinal information on the patient. In the acute sector, it does, let's say, patient admin systems, order communications, medicines management, and clinical noting. Whereas over in community, it does patient admin, referral management, population health management, mobile clinical management, test results, and clinical noting also. So those are core functionalities that we've defined are kind of going to be required as part of the overall kind of programme. So within the core, in the middle of this bullseye, I suppose you could call it, those functionalities would be at the core, but there are also extended solutions that are in place in Irish healthcare today. So you may be aware, if you work in hospitals, of a programme called NIMS that's for medical imaging, that's rolled out to most hospitals in Ireland already. There is a laboratory system called Medlist that's being rolled out to all hospitals at the moment, and also a maternal and newborn system that's being rolled out to all maternity hospitals. So each of those, let's say, extended solutions will be part of the overall infrastructure and part of the overall programme. There'll also be capacity at the outside of this ring for innovative solutions, so where there's specialist solutions in certain areas that have got better functionality or better capability than what's available in whatever the infrastructure ends up being in the core and the extent that those can be accommodated also. And that again just illustrates, I've kind of touched on this in the previous slide, but that illustrates the functionality that we're building into the overall kind of systems that will result from the programme. And here's just another, I suppose, illustration again of kind of where the e-pharmacy programme fits, where, let's say, there's a medical oncology system also that's out for procurement at the moment, how they'll all, I suppose, hang together as part of an overall system, moving towards a singular system and a single solution set over time. Features of our approach, I suppose, maybe that we're focused on delivering solutions to the public, and almost calling it maybe person-designed healthcare rather than kind of place-designed kind of healthcare information. We're looking at doing a phased and modular approach, so we're not trying to bite everything off at once. We're looking to define kind of specific projects within the programs that can be executed and done in a realistic and pragmatic way. We're doing detailed kind of deployment planning. We're differentiating between the kind of existing programs and the new EHR capability we need to put in place. We're looking to, I suppose, leveraging the pan-government infrastructure. There's not just, let's say, telecoms infrastructure in place that the government controls, but there's also, let's say, citizen sign-on functionalities that we're looking to integrate the programme into. It will be based on a kind of a cloud-first policy, so we hope to be a lot more agile as an organisation in terms of how we can deploy. We do a lot of internal provisioning of kind of systems and machines that can sometimes take some time at the moment. We'd look to support innovation. Ehealth Ireland has got, I suppose, a dual mandate, primarily for the health service, but also towards Irish industry, allowing for Irish innovative companies to, I suppose, establish a product and establish a capability in the healthcare sector. And our approach is not to rip and replace the stuff that's working there at the moment. Here are just some kind of indicative costs. The costs are significant. So to make this programme work, we believe in the order of 80 million euros a year, which is about 0.6 or 0.7% of the entire healthcare budget would be required. And we've defined kind of very outline programs in terms of which organisations could be made electronic by when. So we would have a phased approach. So it would be by hospital group or by community healthcare organisation would be the main, I suppose, nodes of activity around deployments. And there's just some modelling around that. There's some dependencies, risks and prerequisites illustrated here. I suppose the key to your profession is collaboration is identified as the key success factor. And I'll come to that maybe at the end. We, I suppose, have a design readiness procurement delivery kind of plan in place at the moment, and this is more on the roadmap, which I hope maybe we should be able to share. So sorry for whizzing through this so fast. So there is a governance, I suppose, key to, I suppose, state Dr. Anya Carroll, who's the Director of Clinical Strategy and Programmes, is the chair of the overall programme. So we in IT are kind of suppliers or kind of, I suppose, working under her overall governance. So it's her clinical leadership and her overall leadership is kind of provided to the programme. It will be broken into kind of acute programme boards and community programme boards as the deployments start to be planned in more detail. So this is the kind of half-final slide. So our own kind of key next steps are, I suppose, the HSE board, as of about a month ago, have approved the business case, and we're now in discussions with the Department of Health around overall funding. This is something that have to be built into the programme for government, and that's under discussion at the moment. There's a system reform group that's part of the HSE, which is kind of a key part of all of this as well, in terms of this programme is part of the overall reform programme of the health service. There's other elements in here, I suppose, moving all the way through to kind of commencing procurement activities, etc. as well. One thing to say up front, the HSE has said it's going to, or has approved that it's funding the first year of the programme. So the summary care record element, is something that's already just proceeding. So we're going ahead with the planning of the functionality around that. So if you have any input into that, that would be most welcome. We're relying on Dr. Anya Carroll's colleagues who are designing integrated care pathways around the two priority pathways that they're focused on for those with chronic disease and for the care of the elderly. So let's see. So I suppose the final thing, I suppose, just in connection to make all this, I suppose, relevant somehow. I suppose EHR will support Irish nursing terminologies. There's no question there. Every EHR system should and will be compatible with whatever terminologies you choose to use over time. The one thing I would say is, let's say standards are useful when there's volumes to be standardised. I'm kind of cautious of kind of saying, hey, we need to standardise everything before we go ahead. Having been involved in other sectors, we all know the simple text message on your phone. That was designed as a standard, but not for consumers to text. It was designed as a standard for operators to be able to communicate within devices. Nobody ever envisaged when they developed the standard that it was going to be used for texting. And I'd say probably 95% of all the standards in the world never even see the light of day in terms of practice. So standards are very useful when we have a lot of practice and when we want to standardise that practice. But to me in Ireland today, I'd say from what I've seen in Irish healthcare, we need to do more of the kind of records and professional records management as well. So if I was to ask, I don't know whether I should, how many people here have got unified paper health records in their own care organisations today? I don't know if I'd have, maybe I'll do a show of hands. Who's got unified paper health records in their organisations today? So to me, I would that would be a good place to start as well.
Just to say we're from Northern Ireland.
Oh, okay.
And so I feel like to work in partnership.
Great. So if we don't have, let's say, multiple disciplines working together on paper records, then electronic is not going to fix that. So we need to start with quite a few pragmatic, simple steps before some of these other wider questions that will be complicated get answered as well. So that's it for now.
Thank you for that. That actually it was very interesting overview of the work at hand and the work, I suppose, highlighting the work that we have to do within the professions of nursing and midwifery to inform that agenda. And I forgot, we forgot to welcome our colleagues from Northern Ireland here earlier, so you're very welcome. Can I just say, we're going to have a few examples of, I suppose, just to contextualise this work. My colleagues in County Hospital, Deirdre Brennan and Louise Geraghty, back a year or two ago, looked for some funding to develop the documentation in County Hospital, and they've worked with Richard Corbett in developing a learning site for the implementation of what's going on with the Ehealth in that office to do with the Ehealth Strategy. And so their model, I think it's true to say, was actually they were basing their model on the CHOB, the Canadian Health Outcomes for better outcomes. And in discussing it with Mary and with the team in the Office of the Nursing Services Director, it came to my attention that there was work being done in St Vincent's in Isle Park, and the model, and Trace will talk to you about that model. And I suppose it became apparent then that there's pockets of work being developed around the country, Cork, the Galway Clinic, and there's a requirement maybe for us to actually have exposure to a variety of different models and decide on how we can actually integrate this, because as Fergal said, we shouldn't have Heinz 55 variety. We really need, and particularly for nursing now, we need to actually have the architecture built around our terminology, and that we're not fitting into an architecture that isn't able to facilitate the whole area of nursing language, nursing diagnosis. So Trace, and I apologise, the time is going to be short for everyone, but Dr. Trace Meehan is actually going to talk to you about the model in St Vincent's Ellen Park. Trace is a diploma in nursing in Auckland, New Zealand, and a Bachelor of Nursing in Pennsylvania. She did a Master's in Nursing with minor in Education and her doctoral studies in New York University, so she's quite broad international experience. Her nursing care was predominantly her expertise in the area of acute care in adult services in general nursing, and she has also experience in nurse education. Her research background was in New Zealand, and also she was Assistant Director of Nursing in the USA, and she led the first study to identify nursing and midwifery research priorities in Ireland. Her historical research has led her to develop an appreciation of I suppose, the knowledge and practice of nurses within the 19th century, and this contribution informed the early development of modern nursing. And this appreciation, along with her education, has led to the development of her careful nursing philosophy, on which this model is based. So, do you know how to do this?
Thank you, Edna, and hello, everybody. Now, Carolyn and I are going to go over with you the whys and hows of using a group of standardized nursing language systems, NANDA, NOC, and NIC. Now, NANDA stands for the North American Nursing Diagnosis Association International, NOC, Nursing Outcomes Classification, and NIC, Nursing Interventions Classification. Now, these languages all work together. They work off one another. At St. Vincent's Hospital, we are using them within the context of careful nursing, which is the model which the hospital has adopted to guide nursing practice. And this model sort of has two aspects, I suppose, overall. One has to do with providing a healing environment for patients and for nurses to work in, for kindness and caring in our practice. And the other has to do with the specifics of clinical practice. So when you look at this here, you see there are a range of concepts or values, and there are two highlighted in red. One is perfect skill, and this relates to accuracy in our practice, and the other, diagnoses, outcomes, and interventions. So you might wonder, why then have we chosen this set of standardized languages? Basically because we think they're the best and they work the best. They're the best research set of languages. So we have evidence-based practice right there. They've been developed since 1982. Since 1986, there are over 1,000 articles in the nursing literature about their development, the research done and related to them, and how they're used in practice. They're mapped onto SNOMED, so that they're easily translatable into the umbrella electronic system that's used by all of the healthcare disciplines. So they have numbers that link into that system. They're linked to measurable nursing-sensitive and midwifery-sensitive outcomes. So we get to measure the effects of our practice. And I mentioned midwifery there because there are a suite of diagnoses that are specific to midwifery. They're the most widely used internationally, all over the world, just about. And that's important for us here in Ireland because we have many nurses, for example, who come from the Philippines and from India. And most of those nurses learned NANDA, NOC, and NIC in their basic education. They're used in most fundamental nursing textbooks, and they would be predominantly NANDA, NOC, and NIC because they drive a very high-level nursing assessment, and they set out steps for care planning that are easily followed and work very well for students' learning. They require and give guidance to a high level of patient assessment, and I cannot emphasize this enough. And I'm going to be talking about the defining characteristics and related factors that have to do with doing this high-level assessment. They're practical. We've demonstrated their usability at St. Vincent's, also at St. Francis Hospice in Raheny. And I have to say now, I have a colleague who's a community health nurse, and he goes out each day and he uses NANDA, NOC, and NIC because he has an app on his iPhone. And so he has his diagnosis, outcomes, and interventions at his fingertips. So that's pretty good, I think. And so obviously there are supportive apps available for using this system. Now, what are these standardized nursing languages? Well, first of all, a nursing diagnosis and a clinical judgment. Essentially, nursing diagnoses have to do with human responses and vulnerabilities to illness and treatment of illness. And so we need to relieve problems, reduce risk to patients, promote optimum health. But before we can do this, we have to know what the problem is. Now, diagnosis means accuracy, and that's why we use the term diagnosis rather than nursing problem, which we used to use. So NANDA diagnoses have built-in accuracy with these defining characteristics and related factors, which I'll talk about in a minute. And there are currently 235 NANDA diagnoses. Now that sounds like a lot, but in any one practice situation, there would be about 30 that would relate to those particular group of patients. And in terms of that group, for any individual patient, probably you would choose from 4 to maybe 8 diagnoses, depending on the patient's nursing needs. There are 3 types of diagnoses: problem-focused, undesirable human responses that we need to address. They're risk-focused, vulnerabilities that patients have that we need to protect them from, and health promotion-focused. Now the outcomes, the standardized nursing outcomes, an outcome, a behavior, a state of perception measured along a continuum. And a key factor with these standardized nursing outcomes is that we can measure the effect of our practice. We can see where we're coming from and where we're going, and we can track that. So that is actually absolutely key to be able to show the effectiveness of our practice. There are currently 490 outcomes to choose from. And then the nursing interventions, the treatments that we provide for patients, essentially for nursing any treatment based on clinical judgment and knowledge that a nurse performs to enhance patient outcomes. There are currently 554, but typically these are mapped to policies and procedures of the institution that they're being used in. Okay, now, the question is, so what about these? How do you use them? How does this work? Now just imagine if you're taking care of a patient who is not taking their medications. Problem with the medications. But what is the problem with the medications? And why isn't the person taking them? Is it a knowledge deficit? Do they not know enough about the medication? Or are there some other problems going on? So that needs to be identified clearly. And so there are a couple of possibilities, at least here. And one would be knowledge deficit. Now this is a nursing diagnosis. There's a definition, defining characteristics, and related factors. So this is driving assessment. These defining characteristics and related factors are driving assessment. This is what the nurse is looking at in order to make the definition, the diagnosis. Now, it may not be that. There may be some other problems the patient's having, so you look at another one. Non-compliance. Person is not compliant with this medication regime. They may know all about it, and they may know the importance, but for some reason they're non-compliant. So here you have defining characteristics again, and a number of related factors. It may have to do with the health system. It may have to do with the provider. It may have to do with the healthcare plan that the person has. There may be financial barriers. It may be the individual themselves, some kind of cultural incongruence with what's happening, and it may be a network problem. So do you see the importance of the defining characteristics and related factors, and the importance here in driving accuracy? Now, I just want to show you a risk for decreased cardiac tissue perfusion. This is an example of a risk diagnosis, of which there are a good number. But see again the risk factors, the pointers for assessment, what a nurse needs to assess to determine whether or not this is happening, or if there may be some other related, similar risk but not the same. And I just want to give you an idea now of how these diagnoses can be grouped into different kind of practice areas. So these are just a few that would relate to acute care hospitals. I added in the bottom one because I think risk for mistaken identity is something we need to always have in there. But community or public health, midwifery, psychiatric illness, intellectual disability, a care of sick children, our registration areas. Or we could look at our general practice areas, heart failure, palliative care, diabetes, oncology, dementia, and after surgery. So you can see there how they can be used, even though there are a large number that's really a good thing because you can draw on the specific ones that relate to your practice area. And I want to give you an example of how the diagnoses, outcomes, and interventions link together. This is how they work. And so we're talking a lot about nursing. We want to talk about midwifery here. So, a diagnosis, ineffective breastfeeding. So you have a definition there. There are 15 defining characteristics and 17 related factors. So, you make this diagnosis. Your next step is to look at what you need to do here. What kind of an outcome do you need? So you look at the outcome next. And what you do is you look at the outcome here, obviously breastfeeding establishment, which can range from not adequate to totally adequate. So at the moment, it's actually not adequate, which is why you have this diagnosis. So you measure this outcome. So maybe say it's about a 2 or so, and you want to get to 5. So you're going to use an intervention. So you measure the outcome at the beginning when the diagnosis is made, so you have a baseline. And then every 12 hours, it's measured and recorded. And so you can see, you can track how you're progressing with your intervention and how the mother is progressing with the breastfeeding. So the measurement, Carolyn will be giving you some examples of that, but that is, it's very easy to do. And we've done semi-electronic care plans already, and it's clear in the semi-electronic care plans that the measurement is always there, and the nurse can always see it and track it. Now, one last point I want to make is about collaborative problems. Nanda, Knock and Nick include this whole concept of collaborative problems. These are at the overlap between nursing and medical practice, where we are all the time, at that overlap, monitoring everything. So we have the medical diagnoses, intermittent attendance of the doctors, and we have the nursing diagnosis, midwifery diagnoses, who are always present with the nurses and midwives, and as well as their nursing work, they're always monitoring and watching 24/7 for collaborative problems, which are physiological complications that nurses monitor to detect onset or change in patient status. And so these can be different things for different kinds of problems people have, but hypertension, atrial pneumonia, bleeding, seizures, etc. So these are key, and they're the key to this overlap. And you'll see on this semi-electronic record that we have that the collaborative problems are identified. So they're checked, and the nurses know what they are. They're checked all the time. And just to show you that there's a huge textbook there. There's lots of guidance here with all of these diagnosed outcomes and interventions. There are great textbooks that show the links between them and that show the individual diagnosed outcomes and interventions. This one does in detail. It's Nanda, Knock and Nick with collaborative problems. So now I'm going to hand you over to Carolyn, who's going to tell you about how this all works in practice.
Thank you, Therese. Okay, so about 5 years ago we looked in Vincent's at our practice and we decided to do a full review, looking nationally at what the scene was. And again, with Staffordshire was very much in the news, and we all recognise that there is a crisis within nursing and caring, and certainly playing out within the media. So we needed to review and strengthen our practices within St Vincent's. In particular, we wanted to look at nursing accountability and compassion within nursing, and also our assessment accuracy and our ability to monitor and define patients who are at risk. So we looked at the literature and we talked to our academic colleagues within UCD, and it was decided that we would go down the professional practice model. And the reason we did this is because it's values driven. Within our organisation, we're very keen to keep and endorse within nursing the values and the mission that we have within the hospital. So a professional practice model really fit with us. What did we want to get out of this whole big change in practice? There was three things. We wanted to increase the visibility of nursing within the multidisciplinary team. We wanted to give nursing a stronger voice. We wanted to increase the nurse's sense of control over their practice, because literature would say that if you have a greater sense of control, there's a higher increased turnover rate is decreased, and there's a higher retention rate. And then we also wanted to measure the nursing contribution to patient care. So the upshot of all of this was we took on Therese Meaden's model, professional practice model, care for nursing. And it's the first and only Irish professional practice model. And I must say I certainly endorse it. There are two elements of the model that we decided to focus on, because if you look into the research of Therese's model, it's quite extensive. But we decided to pick two areas that we could tackle within a realistic setting. So we picked the therapeutic milieu, which is the ward environment, and it looks at contagious calm and how nurses care for themselves and care for patients. And we also looked at professional practice, competence and excellence. And in doing that, we needed to go through the literature to see what was the best way to demonstrate this. The systematic review looking at the standardised nursing languages that was published in the International Journal of Nursing Studies, as Trace had said, had over 1,000 journals reviewed, and they took on 312 journals, articles, as part of the review. There were two things that came out of that. It said, the conclusion is the evidence supports the successful integration and use of electronic health records for two systems, Nanda and NOC and the OMHA system. And 72% of all of these articles focused on the Nanda and NOC. So it is a very well researched and established model. So we knew there would be a lot of challenges to change practice within an entire organisation, so we needed to look at them. So initially, all of our paperwork is freestyle. And as I'm sure some places here may recognise, there's actually a very weak relationship between nursing assessment and the actual interventions that you see written down. So we wanted to try and address this. And then there is, within our organisation anyway, there's even less evidence of evaluation of patient care. A lot of great assessments done that didn't relate to what nurses were actually doing for their patients. It wasn't documented, the great work that was being done, and then there was no evidence in the documentation of any evaluation. This paper-based system needed to be changed. So we looked for a new concept, which was care for nursing, and our new language, which was Nanda, NOC and NIC. So we required very considerable buy-in from senior managers and frontline staff. This required a really large education and training system to be put in place. So we got a team together with the help of NMPDU, and we considered that we'd need a lot of ongoing support. Again, resources, a lot of resources required, but if you want to do something, you do, and you aim to do it right. So you put a lot of time and energy. And again, the cost is a big implication. So the license for Nanda, NIC and NOC is a consideration. However, we had learned that over in the States, they have used adapted versions which didn't have the same cost implications. So nursing assessment was the greatest thing that we got out of this, because by using the diagnosis, you really need to know your patients. What we found with the nursing diagnosis, this is an example of the diagnosis that we use for one ward. Okay, so as you see, there's 28 diagnoses. That's for a very busy thoracic and vascular specialty. So the nurses are very familiar with the diagnoses that relate to their patients, and they become confident. For the outcome scoring, again, you need to know your patient in order to score them, and that's the value of this system. You have to look at their clinical indicators and score them on a Likert scale, as Trace had said, from 1 to 5. Again, I love this quantifiable piece. This is something that our senior managers, our ADONs and our CNM2s can look at the patient workload within their clinical areas. And we're going to integrate that into our patient flow system and have it recorded on a daily and shift-by-shift basis. This is what our care plans look like, and this is what we write. Over a 48-hour period, this is the amount of writing that has been done for one patient. So again, the slept well, due meds given, all these pieces of not so accurate information are gone, and all we talk about are the variances from care. So you get to see the really important pieces of information collated together for your patient. We have a big cohort of student nurses, and what we found was the students were learning things in college, but as my colleague Jacqueline Burke would say, when they come out to the clinical setting, they weren't using it. Their textbooks all give them the nick and knock terminology. So it was actually very refreshing. The students said to me it was very refreshing to come out to the clinical setting and actually see some of it in practice. With the pilot scheme, we looked at the control over practice, and we saw that there was a significant increase, statistically significant increase in their control over practice, in the nurses' autonomy and in their control over the unit. Also, their adherence to hospital nursing documentation standards increased by 30%, and this is a very big, robust system, which actually correlates with structure, patient education, legal aspects and nursing care, and we have integrated a lot of our nursing metrics when we look at that. So overall, after the pilot ward, 6-7 wards later, we still have an increase of nearly 20% in standards of documentation using the new system. Again, with our national quality care metrics we've collated it for the last 12 months, and we have an average of 11% improvement of the careful nursing documentation as opposed to the standard wards. So this is very good because it shows from a national perspective and the national standards we're doing very well. What the nurses have said, what was beneficial about the new NANDA, NIC and NOC system. It prompts you what needs to be done. Better documentation helps with progressing your patients, and it's organised. Nursing orientated. Need to think nursing before writing. That's an interesting statement. It saves time. Have more time for care of patients in the morning and less unnecessary writing. What were the challenges? And indeed, you can imagine there are significant challenges. Initially, the outcomes and diagnosis were challenging, but the more I used it, the more I got more confident with it. The outcome indicators don't make any sense without reading the book. It takes a lot of time and effort to read and do the care plan. And to me, that's actually very encouraging because it means in nursing, we're here for a reason. We're professionals. We've done 4 years as an undergraduate degree. We need to be thinking about our patient care, not just doing our ritualistic tasks. And it can be hard not to write sometimes. And again, I would hands up on that one. And initially, families thought little writing meant patients weren't being cared for. But it's a whole change in culture. And we asked the nurses to explain if and how the new documentation changed the way they approached their nursing. And they said there's more time in assessment, planning and evaluating. So more time to interact with patients and relatives. Formally assessing patients weekly was good and can see if your patient is improving. Ensures issues like continence and mobility are updated and clear to any bank nurse, and I think we can all identify with that one. Makes nursing more visible and more clear what nurses do within the multidisciplinary team, so that has certainly achieved one of our aims. And we question and discuss more. And it seems like no change and that standards remain the same, but we have more time to spend with our patients. So again, it's all very encouraging. It helps us with our quality assurance. Again, with the metrics, we have endorsed that the documentation is working. With NMBI next year, they come for a site visit for our undergraduate nurses, and in our last QIP, they had asked us to provide evidence of a proper model and use and documentation, so now we actually have it. And then with HICWA, it was very helpful when they came in to do their nutrition and hydration audit, and they looked for evidence of care planning. We walked down to the first ward, I went to a nurse, and I said, have you any evidence of care planning to do with nutrition and hydration? She went straight over to the computer, pressed print, and handed it to the auditors. My jaw dropped and so did the auditors, but I was delighted. So the future for us, continue to embed practice and culture. We're going to integrate our handover standards with NANDA, NIC, NOC and the ISPAR and use it within our electronic patient flow system. Therese is going to publish her final study, and it's nearly there. We're going to develop an e-learning module on NANDA, on NIC, on NOC and on careful nursing, and we're going to look into the use of mobile apps. We're going to bring it hospital-wide and integrate it with our quality and safety team within the hospital. And then we're going to consider the pathway to excellence journey, which hopefully in time may bring us to the whole journey of the magnet hospitals, which again helps with patient quality and retention of staff, which I think is a big issue for all of us. So finally, it's a platform to contribute and lead on international research. It values demonstrated in the semi-electronic version which we've used in Ireland. It integrates with collaborative terminology and e-health systems. It consistently articulates nursing clinical decision-making and clinical reasoning for safe, effective professional practice. It's applicable to all nursing levels and registrations. It's evidence-based standards, and we can use it within the Irish healthcare sector. and it's the most widely accepted international nursing language. And just to finish, these are the quotes of my colleagues. Nursing is more visible. We have more time to interact with our patients. It has helped nursing confidence. And you need to think nursing before you write. And I spend more time in assessing, planning and evaluating. And I don't need so much time in documenting. Thank you.